Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects, as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Good evening, one and all. I welcome you all to today's Navigate Medico CME program. I would like to invite Professor Umesh Kapil Sir, the Secretary of the National Academy of Medical Sciences, to deliver the welcome address.
Am I audible, Preeti?
Yes, sir. The volume is low, but it is audible.
My apologies for a poor connection. I'll speak loudly. Is it okay now? Okay,
Yes, sir.
good. On behalf of National Academy of Medical Sciences, I welcome all the speakers, all the participants, and all the coordinator, Dr. M.B. Padmaji, my senior colleague at the All India Institute of Medical Sciences. My most humble and thankful welcome to Dr. Rajesh Kumar Singh, who is the speaker for today's CME. Dr. Rajesh Kumar is a faculty member, senior faculty member with Department of Neurology at All India Institute of Medical Sciences. So, we are most grateful to you for joining. The present Navigate CME program which we have initiated is essentially for the PG, either who are doing PG or they are planning for the MBBS students, MBBS passed out students for preparing for their postgraduate examination. The theme of effective management of common neurological diseases was agreed upon by Dr. Padma and National Academy of Medical Sciences. And this is the third lecture in the city, and we are sure that all the participants would really love to hear to Dr. Rajesh Kumar ji. His topic is multiple sclerosis and other demyelinating diseases. I hand over to Dr. Preeti to further continue the session. Thank you, Dr. Preeti.
Thank you. And I would like to introduce the speaker for today's session, Dr. Rajesh Kumar Singh, who is an associate professor in the Department of Neurology at AIIMS, New Delhi. His areas of specialization includes neuroimmunology, neuroinfection, and stroke. He has around 60 publications to his credit. It's a honor and a privilege to have you here, sir, for the talk. Over to you, sir.
Thank you, ma'am, and thank you, sir, for a kind introduction. Should I start now, sir, the presentation?
Yes, please.
Okay. So today the topic of my discussion is multiple sclerosis and other demyelinating disorders. So the outline of my lecture will be multiple sclerosis, then MOG-associated diseases, NMO, and other demyelinating disorders. So we know what is multiple sclerosis. It is a chronic disease characterized by inflammation and demyelination of the CNS associated with axonal as well as neuronal damage. Previously, it was considered as a disease of the Western countries, but now with the more recognition, with the more investigations, what we are having MRI, the MS is not, at least not less, but equally common in our country also. So how the evolution of the disease is multiple sclerosis. Initially there is preclinical activity, then there will be relapsing and remitting, means there will be attack, there will in some form of attack, then it will improve, either some improvement either spontaneously or with the treatment, then again it will relapse. So this will be this is the most common presentation of multiple sclerosis, which is called relapsing and remitting type. Some of the forms after relapsing and remitting type, the disability progresses and keeps on accumulating the disability. You can see here, keeps on accumulating the disability with the time. Then that portion is called progressive MS, that is secondary progressive MS. Sometimes the multiple sclerosis is in the beginning also it is progressive in nature and with minimal relapse. So that is called primary progressive multiple sclerosis. So now, there are few terms which are always being confused. What is dissemination in space? What is dissemination in time? How to diagnose multiple sclerosis? So actually, these terms will be used in the McDonald criteria and will be used how to diagnose multiple, how to apply the criteria. So it should be clear, very clear in the mind, what is dissemination in space. Dissemination in space means on the brain in the MRI, or the lesions are not single. It is disseminated. It is at more than one site. That will be called dissemination in space. Second is what is dissemination in time. Dissemination in time means the lesion is also not one time. It is the lesions are keep on accumulating with time. This the whole the terminology the meaning of this is that the disease is progressive. Disease is not involving at one site, and so this is being used for the definition of multiple sclerosis. So how will you determine the disorder and dissemination in space and time? So one will be clinical history. By clinical history, by objective clinical evidence, then the imaging, MRI, and CSF OCB, how we will discuss in the further slides. Yeah. So before putting the criteria, the McDonald criteria, I want to tell that we should first what are the typical syndromes of the MS. We should know that, because if we apply the McDonald criteria to a person who present first time with 50 years of age, then we will falsely diagnose MS. So this McDonald criteria has been validated for the typical syndromes. So what are the typical picture of MS? It is usually unilateral optic neuritis. It is mild, improves on treatment. There can be INO and that can lead to diplopia. There can be trigeminal neuralgia. There can be facial sensory loss. There can be cerebellar syndromes. And also the spinal cord syndrome is also partial. It is not like acute transverse myelitis complete. The age is also younger in onset. It is not more than 40 years. And the atypical pictures are when it is bilateral. When it is severe, it is not responding. When there is complete long segment myelitis, which is not responding. The presence of severe cognitive impairment, seizures. These are the pictures which are not typical for the MS. So we should not apply McDonald criteria straight away in these patients. So I was telling how will you be objective evidence of the dissemination in space or dissemination in time? How will you objectify it? There was a lesion. So there can be clinical evidence, there can be radiological evidence, and there can be paraclinical evidence. So suppose the patient has once optic neuritis. It is not now presenting with optic neuritis. The patient presented with some other syndromes, but he gave a history that he has once a vision loss about 1 month back. So that we can, by the history, it was acute onset to peak was around 3 to 4 days or 5 days associated with periorbital pain. We can make out it must be around optic neuritis. So what is the evidence? So either the patient has some visual blurring, has some decreased vision, left residual deficit, or he can have relative afferent pupillary defect in that eye. So similarly, for the myelitis, he can have a hemisensory level, he can have persistent weakness. So this is the clinical evidence, which in the past, which we can distinguish now. The radiological, there can be hyperintensities on the, for example, in the optic neuritis, the hyperintensity in the optic nerve can be present. VEP, prolonged VEP, OCT showing optic nerve thinning. So these are the things which we can objectively say that these are the objective evidence of the past attack of some form of multiple sclerosis. So again, the two terms always sometimes confused. What is radiologically isolated syndrome? What is clinically isolated syndrome? So radiologically isolated syndrome, a completely healthy person and asymptomatic person, sorry, and he has been just imaged for something else, and we found that there are lesions which are filling the dissemination in space criteria. So it is not MS. Thus, we can say he is a radiologically isolated syndrome. In future, we don't know whether he will progress into MS or not. Similarly, clinically isolated syndrome means it presents with a clinical episode which lasts for more than 24 hours, but it is not, MRI or imaging is not filling the criteria for McDonald criteria for the diagnosis of MS. They can also later on turn into multiple sclerosis. So for the radiological lesion in MS, there can be focal hyperintensity on T2 and flare. These are round or ovoid in shape, and at least it should be 3 mm, and it should be visible in at least 2 consecutive slides to exclude artifacts. So what we look for dissemination in a space is initially we used to look at 4 areas. One is the periventricular. These are the typical Dawson's figures, the periventricular, then juxtacortical, then in spinal cord, then the infratentorial in the cerebellum, brainstem. So these are the 4 sites. When it is more than one site, for example, it is the periventricular lesion, one is a spinal cord, we can say that dissemination in space is present. The demyelinating lesions are present at different part of the brain nervous system. And when we call dissemination in time means the lesion is not at one time. So if we have a baseline MRI of a patient, suppose a patient has been imaged anywhere previously 1 or 2 months back, and now when we have repeated the imaging, we can see that here the new lesions have appeared. This means it was not previously present. So the new lesions, appearance of new T2 or flare lesions, or contrast enhancing lesion. Contrast enhancing lesions means it must be a recent one. So we can assume that this is a recent demyelination episode. So either the new gadolinium enhancement or new T2 lesions, these we can collectively call the dissemination in time is present. One point I want to highlight here, sometimes the MRI quality varies. For some of the periphery, 1.5 Tesla is used. Here, 3 Tesla is used. So the lesions which are not appearing in the previous and appearing in the new one, we should think cautiously, because that the 3 Tesla machine or the thin section MRI, the lesions can have missed in the previous one. So this appearance of new lesions, you should also keep in the mind the quality of the image. So how the diagnostic criteria have been evolved? We know the dissemination in space and time was first introduced in 2001. Then 2000 McDonald criteria was revised in 2010. Now 2017, and now in 2017, the CSF oligoclonal IG band have been introduced to for the dissemination for keeping the diagnosis when dissemination in time. So this was the 2010 McDonald criteria. So we have to remember this if we have to apply the criteria. Yes, the one is the clinical attack, one was the objective evidence of the lesions, and what further we need to do. So, some example, the patient has 2 clinical attacks in the past. Suppose the patient give history, okay, he has a optic neuritis. He has one history suggestive of optic neuritis. He has one history of hemiparesis or paraparesis suggestive of myelitis. So we can assume that he has 2 clinical attacks. So there should be objective evidence also. For example, if I have to, as I told earlier, if the patient has RAPD or residual vision, that means it was collaborating with the previous optic neuritis or residual paraparesis or hemisensory level or something like that. So when there are 2 clinical attacks, we find the objective evidence of 2 clinical lesions, then nothing is required. It will be if MRI is satisfying the criteria, MRI is having demyelinating lesions, we don't need dissemination in space and time for that. Second is, if it has 2 clinical attacks, then we can only one evidence. For example, we are not finding the optic neuritis attack currently in the current examination. There is no residual vision. There is the vision is 6/6. There is no RAPD. Then what we need to have MRI dissemination in space. What do you mean by dissemination in space? As I discussed, at more than one site, at least one or more than T2 flare hyperintensities, at least more than one of the areas. That is juxtacortical, infratentorial, periventricular, and spinal cord. Then if we have only one clinical attack and evidence of 2 objective lesions, some of the patient can have cerebellar signs, but they have no they didn't remember that they have acute onset ataxia in the past. So in that case, we can find there is objective evidence of or have pyramidal signs. So if we find the objective evidence, but he remember only one clinical attack, then we have to find dissemination in time. Similarly, if one clinical attack, one evidence, then we have to find dissemination in space as well as dissemination in time. One is the primary progressive MS. The definition is either retrospective or prospective. 1 year of disease progression should be there. Either he is progressing for last 1 year, or we have examined today and for the next 1 year he is progressing. And at least 2 of the following should be present. What? Dissemination of space in the brain, dissemination of space in the spinal cord, and positive CSF. Either 2 of the will qualify for the diagnosis of primary progressive multiple sclerosis. So this is what I have just told, how the dissemination in brain, more than 2 lesions in one area, more than 1 areas of the brain. Spinal cord, dissemination of space in the spinal cord is more than 2 lesions in the spinal cord, and positive CSF oligoclonal band or is the IgG index. So now the 2017, the McDonald criteria has again been revised. There are some, it is almost more or less, it is the same, but some things, fewer things have been added. One is the presence of the oligoclonal band in the CSF can be used as dissemination in time. So if MRI, we are not like PPMS, this was there, but in also for the diagnosis of MS, if the relapsing and remitting MS, if the CSF oligoclonal band, it can be taken as dissemination in time. So and few things more have been changed. This may be important from the MCQ point of view. Also, previously cortical were not taken into account, but usually the juxtacortical juxtacortical lesions were considered, but now cortical have also been included. And third, previously for the counting of the demyelinating lesions, the symptomatic spinal cord and posterior fossa lesions are not taken into account, but now they can be taken. They can be taken even if they are symptomatic. So these, and the third one is the CSF OCB for the dissemination in time. These are the changes which have been included in 2017 criteria. So I already told cortical lesions for dissemination in space. Both symptomatic and asymptomatic lesions can be used for dissemination in space and time. And CSF OCB can be used for dissemination in time. For PPMS also, the definition more or less remains the same. So I found this mnemonic MRI red flags for the diagnosis of multiple sclerosis. So mimics We can say if there is meningeal enhancement, it is very unlikely. If it is increasing lesion size increasing, it is unlikely. Microbleeds, macrobleeds, infarcts, cavities, complete ring enhancement, sparing of U fibers, sclerosis. These are the few typical imaging findings which are having red flag signs. These are against the diagnosis of multiple sclerosis. So one more term we frequently encountered, that is what is NEDA. So how we monitor, suppose we have diagnosed the multiple sclerosis. Now we will treat it. We will treat with the disease modifying drugs. So how will you monitor whether the patient how will we monitor the response to the treatment? So previously, previously it was like either we can say that patient has no clinical relapse. Whenever we have started the disease modifying therapy for last 1 year, the patient has no clinical relapse. Good. So it is, but it is not the only the one point. The second point is patients should not have the disability progression also. So for example, the EDS score we use, so there should not be any disability progression. There can be disability progression without the overt clinical relapse. So this point is also important. Third, the patient can have silent MRI lesions. The patient is neither having relapse, neither having progression of the disability, but MRI, the new lesions are keep on accumulating. So there should be no T1 or T2 flare hyperintensities or new lesions. For the brain atrophy, we can have to we can measure the brain atrophy part also by the volumetric assessment of the through the MRI. So these are the four which have been used in various trials. The NEDA4, the no evidence of disease activity. So these four things are being used. Fifth thing is when there is the CSF and neurofilament light chains, we see if it is there, it is showing axonal damage. So even if it is not showing, this means that it is NEDA 5 now. So it is the ultimate goal. We are achieving the NEDA 5. So we measures the disability on the MS by EDSS score. EDSS score has some demerits also because it is mainly measures the ambulatory function. It highlights the ambulatory function more, and also it has high inter-rater and inter-rater variability also. So now coming to the, now we have diagnosed multiple sclerosis. We know how to monitor the response to treatment, how we measure the disability. Now, how we will treat it? How will the clinical, I suppose the patient presents with acute clinical relapse. So this is a forest plots, and every student should know this how to interpret it, how to interpret the forest plots. So this is the point estimate. This is the point of no effect, and this is the confidence interval of the point estimate. So the confidence interval should not touch this line of no effect. If it touches, then it becomes insignificant. So this is what we have measured in this, the effect of steroid treatment on 8-day functional improvement. We have given a steroid. We want to know what is the effect on 8-day functional improvement. These are the various trials which have been it is the meta-analysis and systematic review. We have analyzed the various trials and found that all the trials, some trials are crossing, some trials are also crossing, but this trial, which has the highest weight, maybe it is shifting the direction towards the favoring steroid. So the point estimate is lying away from the null effect, and it is favoring steroid. Similarly, the 30-day is also favoring the functional outcome. So this means that steroid has definite improvement in 8-day functional improvement and 30-day functional improvement in the various trials and this systematic review and meta-analysis. So we also treat acute MS relapse like this. We treat with the steroids, IV, MPS, and there is evidence to support this. Then the second, after suppose we have optic neuritis or acute myelitis, we have given methylprednisolone, there is no response or there is minimal response, then the plasmapheresis we usually give. So plasmapheresis has been documented as a class 1 study. Plasma has a role in the management of exacerbation and relapsing form of MS. So we should give plasmapheresis, and preferably as early as possible if there is no improvement. Third is, should IVIG be given? I frequently found prescriptions from the patient coming that whenever there is a relapse, the patient has been given IVIG. So there is no evidence to support this, and it should be discouraged. Usually we should be given steroids and plasmapheresis. IVIG should be reserved for certain specific certain particular conditions, like in pregnancy or when patient can't be given plasmapheresis. So it should not be routinely used for the acute relapse. Now coming to the disease modifying drugs in multiple sclerosis. So what are the, we have treated the acute relapse. Now we don't want the patient to have further relapse. So we will have to treat with disease modifying agents and probably a long term. So what are the disease modifying therapy, DMT, which have been approved in multiple sclerosis? So it has been from the interferon beta to the mitochondrion to the natalizumab. Now the oral drugs have come, the fingolimod, dimethyl fumarate. Now it is a metozumab, the ocrelizumab. So these we gradually, cladribine, it is also. So gradually we have more and more drugs in our armamentarium, and we should know when to use which drug. Commonly, I found that currently the oral drugs are being commonly used, the dimethyl fumarate or the fingolimod. And when to switch, when to escalate the therapy, when to de-escalate the therapy, or whether we should use, why not we should use the ocrelizumab or rituximab first. So these all, since we have many drugs, we have options, but we should prioritize which drug to be used in certain special settings. So this is a network meta-analysis. Network meta-analysis is mainly used when we have multiple drugs for one disease and we want to know which is better or this. And this has been all the randomized DMT, which has been till 2000.
No confidence motion there.
No, I didn't hear anything.
Yeah. No,
they will have the discussion. They haven't had, they just admitted the thing. Then they have to have their debate.
Sorry,
Then he will
excuse me. Audio, someone talking audio is on. Please mute yourself. Okay, so we were telling this about the network analysis. So all the randomized trials have been included till 2018, and the 15 drugs which have been approved by the FDA for the disease modifying therapy have been studied. And what was the primary outcome? The outcome was the efficacy. First is the efficacy. What is the relapse rate measured by the number of participants who experience at least one relapse over 2 years? So over 2 years, whoever have at least one relapse, that will be used as efficacy. And acceptability, how many treatment has been discontinued over the 24 months. So this is the SUCRA for relapses, the surface under the comparative. This has been over 24 months. So we can see, and this is for the acceptability. So the placebo has the highest acceptability as expected, and similarly the drugs which has more and more these are the drugs which have the list of the relapses. So these must be the potent drugs. So it is evident the fingolimod. So for just want to say that for in the oral drugs which are commonly used, the teriflunomide is commonly used, dimethyl fumarate is commonly used, and the fingolimod is commonly used. So in these three drugs, I found fingolimod to be more potent as compared to dimethyl fumarate, which is more as compared to teriflunomide, just on the basis of this network analysis. In the intravenous drugs, almetuzumab, ocrelizumab, natalizumab, these are almost have compare efficacy. The mitochondrion is also effective, but because of the cardiotoxicity, and we are not using it very commonly. So, so why we should choose to first use fingolimod? Why should not we use should be natalizumab first? So, either there are two approaches have been discussed. One is the escalation approach. One is the de-escalation approach. The escalation approach means we are finding that this MS is not very aggressive. So we can use the drugs which are less potent and have less side effects, like dimethyl fumarate, like interferon, like teriflunomide. And when the patient is not responding, we can go to further escalate to fingolimod. If not, then further to natalizumab, then further to almetazumab, mitoxantrone. So this is called escalation approach. This is best for the MS which are not considered very aggressive. And for the aggressive MS, we can go to de-escalation approach. The drugs which are very potent, like mitoxantrone or natalizumab or almetazumab, we can start with them and then gradually taper down, or gradually the less potent drugs which can use. So this can be, we can choose the drugs in this way also. So when to consider, these are the various definitions, when to choose highly aggressive MS, how to define aggressive MS, highly active disease, rapidly evolving severe disease. Various studies have just put, but overall, if the patient has more number of relapses in 1 year, have more MRI burden, lesion burden, young patient, male patient, having become wheelchair bound within 1 year or within 2 year, 3 year, these are called highly aggressive or aggressive MS. So risk factor for aggressive MS are male, age, onset, later onset, rapid worsening, and the MRI is high lesion load, new lesions, both the brain atrophy. So the spinal cord and infrartentorial abundance of these lesions also are suggest that it may be aggressive MS. CSF, the ongoing axonal damage reflecting in the terms of neurofilament light chain or OCV. So these are the risk factor, and when we see, we can decide our treatment accordingly. So now coming to progressive MS. So we have studied what is relapsing limiting. Now progressive MS, mainly PPMS and SPMS. There is no clear demarcation between when the relapsing limiting type convert into secondary progressive. So we should be vigilant. We should always try to write the EDSS score so that we can know how disability has been progressed. So now initially progressive disease has been, now from 2013 we simply write progressive disease, whether it is active and with progression, whether it is active but without progression. So what do you mean by active? Active means either the patient has MRI evidence of new lesions or the clinical, and it is progressing, disability is progressing. The patient has evidence of disease activity in the imaging one, but the disease is not progressive, and it is not active but with progressing, and not active and without progression. This is the stable phase, and this is the phase which we can even stop thinking of stopping the DMT. But these active, we need to treat these even progressive disease, which we have limited options, which we will discuss. So the PPMS is used to be non-treatable previously, but yes, ocrelizumab, this trial has shown the role of ocrelizumab. So this is the randomized controlled trial in which 732 patients were enrolled in the 2:1 ratio. This is the population. Intervention was ocrelizumab 600 milligram 24 weekly, 6 monthly. The control was the placebo, and we have confirmed disability progression we will measure after 12 weeks. So this was the trial, and the inclusion criteria was diagnosis of PPMS, EDSS score of 3 to 6.5, duration depending on the EDSS. And what we found that the confirmed disability progression for more than 12 weeks, this was the primary endpoint. We found in ocrelizumab, it is found in 32.9% and placebo 39.3%. And the hazard ratio was 0.76 with p-value of 0.03. So everybody looks at the p-value, but we should also look at the point estimate and the hazard ratio and the confidence interval. So this 0.676 means the 24% there is risk reduction, relative risk reduction of the disability progression in the patient who have been treated with ocrelizumab, which is significant. Since it is not crossing the 1, we can say even without looking at the p-value that it is significant. So not only in the primary endpoint, also the secondary endpoint, like confirmed disability progression over 24 weeks, it is showing about 25% reduction, and other brain volume and brain volume also, the other parameters also, ocrelizumab has shown to have role in the disability progression in the PPMS. So now the practical approach to progressive MS. So this is PPMS. We know that ocrelizumab have been approved, but what about the secondary progressive MS? So most of the DMD which has been approved for relapsing remitting type have written that active, it can be given an active SPMS added to their level based on the assumption that some activity is going on. So an active SPMS refers to the presence of clinical relapse or MRI activity. Active SPMS means the patient is having relapsing remitting type initially, now it is secondary progressive, but the patient has some clinical relapse or increasing in the MRI. So how to treat this active SPMS? For the non-active SPMS, there are no DMTs are FDA approved. So for this active SPMS, what are the options? So we used to treat with mitoxantrone. It was a good drug, potent drug, but cheap drug. But the main side effect is the cardiotoxicity, and now the availability also. The interferon beta 1 beta has found some minimal evidence that it has some role. The oral drug siponimod has found to role in the active SPMS, and cladribine also. So these are the drugs which have been used. So this was the EXPAND trial, which has shown the siponimod versus placebo in the SPMS. And this was the population, 1,651 patients of SPMS. The siponimod was used 2 mg, control was placebo, and the outcome measured was confirmed disability progression. So in this we can see that this is the siponimod and this is the placebo. So there is, again, you can see hazard ratio 0.79. So almost 21% reduction in the 21% relative risk reduction in the patient with 3-month confirmed disability progression. So when we give siponimod, there are 21% chances that the disability progression will be less as compared to placebo. So, and this is the 6-month. It also shows improvement. So and regarding the natalizumab is a potent drug. It has been role has been proved in the RRMS, but does it has any role in the SPMS? Actually, in this trial, there's 888 patients were used. It is a randomized controlled trial. Natalizumab was the drug given. Placebo was the comparator, and the proportion of patients with sustained disability progression. So when the multi-component, that is the whole 25-minute walk test, 90 fit walk test, and whole peg test, and EDSS, whereas a multi-component was used, it has no role. It has some role in the hand function, which is measured by the whole peg test. So more or less, natalizumab does not benefit patients with secondary progressive multiple except some hand component. So what about non-active? We have already told non-active stable patient, we have no FDA approved drugs. So can we stop DMT in these groups? Which are we using? Yes, older age, longer period of stable disease on DMT with absent relapse on MRI, ADCS score of less than 6 are associated with low risk of disease and worsening when stopping. So we can consider stopping DMT in these drugs. Now the rituximab has been now being used like anything in the MS. So actually it is off-label, but yes, there is no in the PPMS, the Olympus trial, it has found no role because as ocrelizumab has anti-CD20, so in secondary SPMS, it is an option, thinking that it may have anti-CD20 activity. So there are cohort studies which have shown in this JAMA Neurology paper also, and this rituximab has been compared with the fingolimod, natalizumab, DMF, and it was found that the rate of clinical relapse and disease activity was significantly lower in rituximab compared with injectable DMTs. Rituximab was superior to all DMT in terms of drug and discontinuation. It was better found as compared to DMF, dimethyl fumarate, and injectable, with borderline significant to natalizumab and fingolimod. But it is a cohort observational study. There is no randomized comparing the drug-to-drug basis. Similarly, it was experience from the developing country about the rituximab only, and it also showed that rituximab has a less, after using the rituximab, the annualized relapse rate is significantly less as compared to what was it before the using of the rituximab. So there are evidence, the evidence is growing, and we can, based on case-to-case basis, we can use rituximab, particularly in the case of SPMS, where we have limited drugs with disease activity. So symptomatic management is equally important. We frequently neglect this part, the fatigue part, which the MS patients have, the urinary complaint, when to advise for CIC, when to advise, when to use antimuscarinic agents, the depression part. The patient has some pseudobulbar sometimes when we can use antidepressants. So these are depression part. So these are the things we should give due importance. I am just skipping because of the limited time. I am skipping this. So when should we use intermittent? We should always measure residual volume. If it is more, then we should more than 100 ml. We should give CIC. If it is less than 100 ml, we can use antimuscarinic agents. We should not use here straightway antimuscarinic because of the cause of urinary retention. So this was about multiple sclerosis. Now I am coming to a case scenario. So a 13-year girl presented with low-grade fever, headache, and vomiting for 2 months. One episode of seizure with secondary generalization, and decreased vision in right eye followed by left eye for the last 7 days. The onset of vision loss was subacute and completed in 1 week. So the girl presented with some febrile illness with headache and vomiting, maybe meningitis and seizure, and followed by vision loss in both the eyes. So on examine, meningeal signs were there. Fundus is showing disc edema. Power was more or less normal. CSF examine was cellular with showing normal pressure, but 150 cells, raised protein and normal sugar. So how to approach? This patient has presented with meningitis like picture. So this was the MRI, and it was showing leptomeningeal enhancement. Then also the flare, some non-specific flare hyperintensity. SWI is not showing microbleeds. This is the contrast enhanced MRI, which is showing the optic nerve enhancement. So now where are we? The patient has presented with meningeal signs and has rightly meningeal enhancement also. The patient presented with bilateral vision loss. So he has features suggestive of optic neuritis with borderline some non-specific flare hyperintensities. So infectious workup was done, which was negative. So secondary autoimmune or demyelinating workup was done. The MOG came, myelin emoji, myelin oligoglycoprotein positive serum, and NMO-NA ANCA was negative. So this we published also that MOG antibody presenting as aseptic meningitis can present with this as of the MOG antibody diseases. Similarly, we have also published the ADEM and evolving strength. So MOG can present like ADEM also. So this was also a case series of 3 papers. So MOG encephalitis, MOG can also present like encephalitis. It can present like tumefactive demyelination there, like in this patient. Leukodystrophy-like presentation. One is the flames. One variant is called flames, or this is flare hyperintensity as well as the diffusion restriction plus seizures. These are the manifestation of MOG antibody diseases. So we should know that MOGAD now doesn't limit it to the manifestation, doesn't limit it to optic neuritis and myelitis only. So besides optic neuritis and myelitis, it can present with encephalitis. It can present with aseptic meningitis. It can present with ADEM. It can present with tumefactive demyelinating lesions. It can present with flames, cortical hyperintensities. So, and the spectrum is still evolving. So it is usually a bimodal distribution with peak around children and mid-adults. Cell-based assays should be done for serum MOG antibodies would be sent. Now just I want to show how we the MOG associated, what is that something usually the MOG associated disorder have CSF pleocytosis is present, and it is more than the MS or NMO, and oligoclonal band is present in less than 10%. What is the optic neuritis, special about optic neuritis in case of MOG? The MOG usually present with anterior optic neuritis, that is perineural enhancement will be there. The disc edema will be there. Papillitis will be there. The chiasmal involvement is less common. It is usually a feature posterior part of the optic nerve or the long segment, or the chiasmal component is more a feature of NMO. Similarly, the myelitis can have short segment as well as long segment, but the gray involvement and which we see H sign, the conus involvement is more features of MOG. So these are the some of the features in the spinal cord, some of the features in the optic nerve by which we can say that yes, it is more suggestive of MOG. When we have compared this to the multiple sclerosis and neuromyelitis optica, we can say bilateral optic neuritis. It is not a feature of multiple sclerosis, but it can be seen in both MOG and as well as NMO. Similarly, the long segment optic nerve, both optic has more a feature of it is more a feature of NMO, and optic nerve enhancement perineural, it is more a feature of MOG. Gray matter spine H sign, more a feature of MOG. Pleocyte is more a feature of MOG. So these are an oligoclonal band, as expected, it is more commonly seen in MS. So these are the radiological differentiating points. Now coming to NMO spectrum disorder, in short, yes, it can present with optic neuritis, myelitis, area prostrema syndrome, brainstem syndrome, diencephalic syndrome, cerebral syndrome, neuropsychiatric syndrome, and uveitis. So area prostrema syndromes, the patient will have nausea, vomiting. The optic neuritis will be severe, can be bilateral. Transverse myelitis will be severe. The patient can have residual disability. Brainstem syndrome can present with ataxia. Diencephalic syndrome can present with somnolence, SID, syndrome of nephroproliferative ADH secretion, obesity, and so on. NMO antibodies are usually present in serum, so cell-based assays should be used and serum antibodies should be sent. This is the diagnostic criteria of the NMO spectrum disorder. I am skipping for the lack of the time, but we should know how to, if the NMO is negative, then how will you diagnose NMO spectrum disorder based on the core clinical characteristics as well as the MRI features. So since NMO is a severe disease, have relapsing nature, so we have to maintain immunosuppression. Rituximab has a role, and in the various trials, it has been proven to be a great drug. Azathioprine we commonly use, mycophenolate, methotrexate, cyclophosphamide. These are actually FDA not approved. These are the drugs which have been approved, which are costly, satralizumab, eculizumab. But we know that these drugs act very well in the animal. So coming to my last case scenario, 21-year girl from Uttarakhand, and she presented with fever for 2 weeks, and a headache and vomiting for 1 week, and progressive drowsiness and paucity of movement in all 4 limbs for 4 days. So again, she presented with fever, headache, and vomiting, may be suggestive of meningitis-like illness, subacute 2 weeks, and some encephalopathy and quadriparesis. So on examination, again, papilledema was present, meningeal signs were present, quadriparesis was there. So CSF was again done. CSF was showing some pleocytosis, quite a high 500 cells, elevated protein, and even low sugar. Infectious workup again, including gene expert, were all negative. NMO, MOG, ANA, ENA, and K negative. Now where are we? So we have started. We did not take the risk. We have started. It is maybe tuberculosis, and since the sugar was also low, in fact, thinking of and other what we do common immunological or autoimmune demyelinating antibodies, they are all negative. So the patient actually presented with meningitis and some form of myelitis. So with CSF side. So this was the MRI of the patient. So we can see here that is flare. There is no hyperintensity. In the contrast one, you can say some sulcus enhancement in the parietal temporal lobes, also on the brainstem surface, which is suggestive of leptomeningeal enhancement. Here we can see the periventricular radial, this pattern. You can see, you can appreciate this is the radial pattern of enhancement on the periventricular part. In the cord accepted, since he was having quadriparesis, so there was long segment T2 hyperintensity in the cervical cord, and there was enhancement along the spinal cord surface in the thoracic and conus medullaris. So what should we do now? Should we treat the patient presented with meningitis and myelitis, having showing leptomeningeal enhancement? CSF is showing infectious picture, but infectious workup is all negative. So we started empirically anti-tuberculous therapy and with steroids in this patient. But because of the presence of meningomyelitis and this linear perivascular radial contrast enhancing pattern, this was very classically described in GFAP. Glial fibrillary acid proteinopathy, astrocytopathy, which was this has been in the various in the study by the in the Mayo cohort. This was a characteristic finding found. So we sent the CSF for the GFAP antibody, and GFAP antibody was found detected in her patient. So we did this patient. So ATT, we have stopped ATT and given plasmapheresis, then maintained her an immunosuppression, and now she is ambulatory. She is doing very well. So the point was that we should also consider GFAP in any patient who present with meningitis, involvement of the brain, spinal cord, in any combination. The meningomyelitis is the most common presentation, and particularly it can relapsing and remitting type also. And the MRI, which is what was the pointer in this patient, was the linear gadolinium enhancement, which was seen perpendicular to the ventricle. This has been described in the 2000 paper, and it was present in almost 53% of the patient. And also longitudinally extensive transverse myelitis was the predominant radiological feature in the spinal cord. So newly recognized and treatable cause of autoimmune meningoencephalomyelitis. It is marked pleocytosis. 1/3 have a malignancy. We have done PET scan in this patient also, and I have screened for malignancy. Fortunately, she was not having that. But yes, 1/3 of the patient with GFAP have malignancy, and it should be done in CSA by indirect immunofluorescent method, as it has a high sensitivity and specificity. Corticosteroids are effective, but because relapse is common, we should consider long-term immunosuppression. And there, as it is a rare disease, so there are no clinical trials for this treatment. But we have kept her on azathioprine. So I want to end my today's discussion that besides this disorder, we should always look for other evidence of demyelinating autoimmune inflammatory condition when the features are atypical, like late onset, then the neurobasset syndrome in the brainstem part, neurosarcoidosis, SLE, Sjogren syndrome. These disorders can also sometimes present with the secondary demyelinating or secondary demyelination, and these disorders should always be ruled out before diagnosing multiple sclerosis and other diseases. Thank you.
Thank you, sir. I would now like to request the participants to ask the questions either in chat or you can raise your hands. So till that time, would you like to assess the participants? Like, do you want to ask some questions which the participants can answer back in chat?
So I can ask some questions. Yes. How will you? This is a common PG question. So how will you differentiate the spinal cord lesions in MS and NMO? Anyone can write or just answer? I think no one is.
There is one answer, sir. Segmental and MS, skip and MS.
Yes. So the skip lesions are characteristic of MS. The lesions are peripheral in multiple sclerosis. It is long segment in NMO, and it is intramedullary, severe, necrotizing type. So yes. Can you tell anyone what is the changes that has the recent 2017 McDonald's criteria have been what changes have been introduced in the recent McDonald's criteria in 2017?
Can you put the answer? I don't think anyone is typing. That is one answer. Dr. Deepansi,
Yes.
cortical Intracortical OCB.
Actually cortical, and the second one is OCB, and the third one is the symptomatic lesions, infratentorial and spinal cord lesions. Now they have been, if they are even symptomatic, they will be counted as number in the number of lesions. Sometimes the patient with MOG optic neuritis, you find it is a common clinical scenario. So I am asking, suppose the patient presented with some periorbital pain and vision loss, and you see that the fundus, when you examine, it is showing disc edema. So so sometimes it is confused whether it is IIH. The patient may have some headache for a few days, and the disc is showing like the PG will, the initial the PG may students may confuse it as it is papilledema. So sometimes it is it is difficult before the beginners to differentiate between the optic neuritis and optic papillitis due to optic neuritis and the IH in the papilledema. In that case, you should look carefully the other signs of papilledema. We should not see just the disc margins are blurred and so it is papilledema. No, sometimes we have seen that the residents have done this mistake, that the patient presented with some headache and the disc was showing some blurred margins, not so overt features of papilledema, and they are telling that it can be IH. So this should be kept in mind. The optic papillitis, the margin will be blurred and it will appear like it is maybe evolving papilledema also, but you should always take. Practically, it is a common mistake I have noticed.
There are no questions as of now. So, would you like to give any last minute comments for should we conclude?
Sorry?
So would you like to give any take-home points, last minute comments? Or
So as I said before also, MS, we should not apply any patient, we should not apply the McDonald criteria straight away. We have to first look exclusion of other causes like other demyelinating disease, secondary demyelination. If it is classically fitting all the MS, if there are other red flag signs for the MS diagnosis, then we should not straight away fix the McDonald criteria. So the point, age more than 40, first time late presentation, atypical optic neuritis, if these are things, we should not straight away fit the McDonald criteria, and we should think of other diagnosis. Means we should exclude other demyelinating disorder before terming it as RRMS or MS. Sorry.
thank you so much, sir. It was a wonderful presentation. It was very clear. It was a lucid presentation. And I hope the PG students will be able to see this lecture again because it will be on the YouTube also. Thank you very much for giving your time, sir. I would now like to invite Professor Ajay Kumar Sood, sir, the Deputy Secretary of the National Academy of Medical Sciences, to deliver the vote of thanks.
Thank you so much, Dr. Preeti. On behalf of the National Academy of Medical Sciences, we are extremely grateful to the distinguished speaker for this evening, Dr. Rajesh Kumar Singh, sir. So thank you so much, sir, for covering this complex topic of multiple sclerosis in a very simple and comprehensive way, giving the practical tips to our students and the participants, and also giving the case example. I think this session will be very, very useful for them from the examination point of view as well. And we look forward for your support in future also. So thank you once again for being with us this evening. I will also like to place on record the support which we have been getting from the chief coordinator for this series, Dr. Padma Srivastava, head of the Department of Neurology, All India Institute of Medical Sciences, for identifying the topics as well as the speaker. So we are really grateful to her for coordinating this particular series on neurology. As far as the participants are concerned, we Well, we are grateful that they are present today, and also they have asked question. So my appeal to the participant, especially the student, is that please disseminate this knowledge about this series on neurology to your colleagues. And the next session is due on 2nd of August. So please remember 2nd of August is Wednesday. And then again, we are going to cover a very important area of neuromuscular disorder. So please tell your colleagues if they have any question, they can always write to us and we can request the speaker to cover those areas in the presentation. I will also like to place on record the support which we have been getting from Dr. Preeti as a moderator. She has been helping us throughout. So thank you so much for being with us this evening also. Again, in the end, I will like to place on record the support by the IT unit of our academy, Mr. Ravi and Mr. Anil, who have been helping us in the background for organizing the Zoom as well as a YouTube transmission. So once again, I would like to thank all of you, and over to you, Dr.
Thank you, sir. Thank you, one and all. I would now like to announce that today's academic session is closed.
Thank you.